First aid is an immediate and temporary care given to a victim of an accident or sudden illness, before the services of a physician is obtained. Characteristics of a good first aider: be gentle, be resourceful, be observant, be tactful, be empathetic and be respectful. Wound is a break in the continuity of a tissue of the body, either internal or external. Classification of wound. Closed wound is an injury in which no blood escapes from the body. Open wound is a break in the skin or mucous membrane. Types of open wound: abrasion, laceration, avulsion, incision, puncture and amputation. To care for closed wound, apply an ice pack to the area beneath the skin. Apply it to the injured area for periods of about 20 minutes. Help the person to rest in the most comfortable position possible. To care for an open wound, apply direct pressure for a few minutes to control any bleeding. Wash the wound thoroughly with soap and water. Cover the wound with a sterile dressing and a bandage or with an adhesive bandage, to keep the wound moist and prevent drying. Fainting is a brief loss of consciousness due to a drop in blood flow to the brain. The episode lasts less than a couple of minutes and you recover from it quickly and completely. Causes of fainting are standing in one place for too long, emotional distress, fear, severe pain, drug or alcohol use, low blood sugar, sudden drop in blood pressure and standing up very suddenly from a lying position. You can take these immediate treatment steps when someone has fainted. Loosen tight clothing. Check the person's airway and breathing. If necessary, call local emergency number. Raise the person's feet above the level of the heart. If the person has vomited, turn onto his or her side to prevent choking. Keep the person lying down for at least 10 to 15 minutes, preferably in a cool and quiet space.
Shock is a condition resulting from inadequate oxygen supply to the body tissues and major organs, and will accompany any injury or illness to some degree. Shock may also be caused by loss of body fluids, damage to the heart, standing still for too long, a sudden emotional shock, fear, pain, or an unpleasant experience. Follow the DRS ABCD action plan and treat the cause of shock if possible. If the casualty is conscious, lay them down and raise the legs. Comfort them, keep them warm and reassure. Do not give the casualty anything to eat or drink. Most external bleeding will be minor and usually stops within 10 minutes through the blood clotting. For minor bleeding, apply direct hand pressure to the wound until bleeding stops. Clean if necessary and then cover with a clean or sterile dressing. Sometimes though, bleeding may be life-threatening if the damaged blood vessel is large or the blood is under too much pressure for effective clotting to occur. To manage major or deadly bleeding, examine the wound for embedded objects, apply pressure to stop the bleeding, elevate if possible, restrict movement and ideally immobilise the part. A significant amount of bleeding may occur with wounds to the head and face. Bleeding is usually controlled with direct pressure, but care must be taken to avoid pressing onto a possible fractured skull.
Check your head here. It's all right. It's okay. It's a bit spongy. Yeah, Frank.
Assess the surrounding area. If a depression, sponginess or bone fragments are felt under the skin, do not apply pressure directly onto the wound. Attempt to control the bleeding with pressure around the wound, perhaps with a donut bandage. Once a fracture of the skull has been eliminated, direct hand pressure may need to be maintained because of the difficulty of bandaging the head firmly enough to control the bleeding. To treat a person with a nosebleed, sit the casualty with the head forward. The nostrils are pinched over the soft fleshy area at the end of the nose bone for at least 10 minutes. Instruct them to spit out any blood, breathe through the mouth and not to blow the nose. If bleeding continues, reapply pressure for a further 10 minutes. If bleeding persists, seek medical attention. When a tooth is knocked out, control the bleeding first, and once controlled, try to save the tooth. Instruct the casualty to bite down firmly on a pad placed over the tooth socket. To preserve the tooth, it may be sucked clean or washed in the casualty's saliva or in a little milk. Water should never be used to wash the tooth, nor should the root of the tooth be handled, as it may cause the tooth to die.
Off to the dental hospital.
In the event of an amputation, firstly manage the stump by applying direct pressure and elevation, then provide rest and reassurance to the casualty. Manage shock, then care for the amputated body part. Retrieve the part and place it in a sealed plastic bag without washing, labelled with name of the casualty and the time of amputation. Place the sealed plastic bag into a container of water and ice and transport with the casualty. When a foreign object, such as a knife, glass, branch or stick, is embedded in a wound, do not remove the object, as it may be acting as a plug. Apply pressure around the object using a donut bandage. Penetrating, embedded or puncture wounds and any bites have a high risk of becoming infected, and medical treatment needs to be sought.
A burn is damage to your body's tissues caused by heat, chemicals, electricity, sunlight or radiation. Scalds from hot liquids and steam, building fires and flammable liquids and gases are the most common causes of burns.
Different types of burns.
For minor burns, including first-degree burns and second-degree burns, take the following action. Cool the burn. Hold the burned area under cool running water for 10 or 15 minutes or until the pain subsides. Don't put ice on the burn. Cover the burn with a sterile gauze bandage. Wrap the gauze loosely to avoid putting pressure on burned skin. For major burns, call emergency medical help. Until an emergency unit arrives, follow these steps. Don't remove burned clothing. Don't immerse large severe burns in cold water. Check for signs of circulation. Elevate the burned body part or parts. Raise above heart level when possible. Cover the area of the burn. Use a cool, moist, sterile bandage, clean, moist cloth or moist cloth towels.
I don't believe I've just done that. Oh, my arm.
Here we go. First things first. Under the cold tap with you. There we are. That's it.
Goodness.
Mummy, you okay?
Oh, yeah, I'm all right, sweetheart.
Now we've got to keep it there for 10 minutes.
10 minutes?
At least 10 minutes to cool the burn. Now, have you got some cling film?
Yeah, just in that top drawer there.
Now keep it there. Out you come. That's it. Wrap it up loosely. You'll feel more comfortable too.
Thank you so much.
There.
Muscle cramp is the sudden, painful tightening of a muscle. First aid management for muscle cramp. Have the victim stretch out the affected muscle to counteract the cramp. Massage the cramped muscle firmly but gently. Apply heat. Moist heat is more effective than dry heat. Get medical help if cramps persist. Muscle strain is the sudden, painful tearing of muscle fiber during exertion. First aid management for muscle strain. Apply cold compresses at once. Elevate the limb to reduce swelling and bleeding within the muscle. Rest the pulled muscle for 24 hours. Get medical help. Sprain is caused by torn fibers in a ligament. First aid management for sprain. Remove any clothing or jewelry from around the joint. Apply cold compresses at once. Elevate the affected joint with pillow or clotting, dislocation and broken bones. Joint dislocation is the displacement of a bone from its normal position at a joint, while broken bone is a break or disruption in bone tissue. First aid management for dislocation and broken bones. Keep the victim still. Prevent infection by covering a sterile dressing before immobilizing. Splint or sling the injury in the position which you found it. Get medical help.
For a sprain or strain, help the casualty to sit or lie down and elevate the injured limb. Cool the affected area with an ice pack or something similar, like frozen peas, to reduce the swelling and pain. Place padding around the injury. Cotton wool would do. Apply a bandage fairly firmly to provide compression and make sure the injury is supported. Test that the bandage isn't too tight by pressing on the nail and checking the colour returns. This shows the circulation is unaffected. Keep the injury elevated. Remember, rice, rest, ice, compress, elevate.
Transfer is moving a patient from one place to another after giving first aid. Pointers to be observed during transfer. Victim's airway must be maintained open. Hemorrhages controlled. Victim is safely maintained in the correct position. Regular check of the victim's condition is made. Supporting bandages and dressing remain effectively applied. The method of transfer is safe, comfortable and as speedy as circumstances permit. The patient's body is moved as one unit. The tallest first aiders stay at the head side of the victim, and first aiders must observe ergonomics in lifting and moving of patient.
The site of an accident is usually an unsuitable location for providing proper medical care. It may be hazardous, dirty, and inaccessible. For this reason, after first aid treatment has been administered, the injured person should be transported to a medical facility as soon as possible. It is normally the responsibility of the person giving first aid to see that the patient is transported safely and without being subjected to further injury, unnecessary pain, or shock. An important rule to remember when transporting an injured person is never move the patient until he has been examined and his injuries have been protected by properly applied dressings. Moving a patient is precise work. It calls for close teamwork and great care. In emergencies or when a stretcher is not available, various carries may be used. Carrying the patient in the arms, and the two-man carry are carries that should be used only when it is positively known that no injury will be aggravated by such handling. The most effective method of carrying a patient without a stretcher is known as the three-man lift and carry. This method is used to transport injured persons for short distances and through narrow passageways. When preparing to lift the patient, each bearer kneels on his knee nearest the patient's feet, on the least injured side. One bearer is positioned opposite the patient's shoulders, another opposite his hips, and the third opposite his knees. The bearer at the patient's shoulders places his hands under the patient's neck and shoulders. The bearer in the center places his hands under the patient's thighs and small of the back. The bearer at the feet places his hands under the patient's knees and ankles. At the command, "Lift patient," the team in unison slowly raises the patient and supports him on their knees. At the command, "Prepare to rise with patient," the bearers slowly turn the patient onto his side so that he rests in the bend of their elbows close to their chests. With the command, "Rise with patient," they all rise slowly. The team of bearers can now, on command, step off in any direction with the patient. The important thing is that all movements must be done in unison, with all members of the team moving at the commands of a leader. There are several types of stretchers used to transport injured persons. The Army stretcher is most often used. It consists of two poles held apart by folding crosspieces and covered with stretched canvas or similar material. The stretcher is tested before placing a patient on it, and the person testing it should weigh as much or more than the patient. The Stokes Navy stretcher is a woven wire basket made to conform to the human body. The patient can be strapped into it securely and placed even in a vertical position for transportation. It is used primarily in metal mines. Stretcher boards have the advantage of light weight, easy storage, and simplicity in use. Like the other stretchers, stretcher boards should be tested before a patient is placed on them. A Bureau of Mines utility splint stretcher is a very sturdy and useful stretcher that can be constructed inexpensively in any plant or mine carpenter shop. In an emergency, a satisfactory stretcher may be improvised with a blanket, gratis cloth or similar material, and two poles or pieces of pipe. To prepare to lift the patient onto a stretcher, each of the four men kneels beside the patient on one knee, the knee nearest the patient's feet. One man kneels opposite the patient's shoulders, another opposite his knees, and the third and fourth facing each other at his hips. The man at the shoulders places his hands under the patient's neck and shoulders. The man at the knees places his hands under the patient's knees and ankles. Both men at the hips place their hands under the patient's pelvis and small of the back. At the command, "Lift patient," the bearers raise the patient, taking care to keep his body level. At the end of this movement, the patient should be supported on the knees of the three men on one side. If the patient is suffering neck, back, or hip injuries, he is lifted just high enough to slide the stretcher under him and not to the knees of the kneeling men. The fourth man places the stretcher under the patient. Again, on command from the leader, the fourth man places his hands in position to support the patient, and on the next command, the bearers lower the patient to the stretcher. When the patient is secured to the stretcher, the four bearers take positions at the head, the foot, and on both sides at the center of the stretcher. On command, all bearers stoop and grasp the stretcher and raise it together. On the next command, the two bearers in the center shift one hand toward the front of the stretcher and support this end, while the man at the foot turns around to a marching position. On command, the bearers step off with the stretcher in unison. Whenever an injured man must be transported, it is important that the handlers or stretcher bearers move together and as gently and steadily as possible to prevent further injury, unnecessary pain, or shock.
Choking. In mild obstruction, the victim is responsive and can cough forcefully, although frequently there is wheezing between coughs. In severe obstruction, the victim has a weak, ineffective cough, high-pitched noise while inhaling, increased respiratory difficulty, and possibly cyanosis. The victim is unable to speak, breathe, or cough and may clutch the neck with the thumb and fingers. Movement of air is absent. The Heimlich maneuver is an emergency technique for preventing suffocation when a person's airway becomes blocked by a piece of food or other object. To do the Heimlich maneuver, lean the person forward slightly and stand behind him or her. Make a fist with one hand. Put your arms around the person and grasp your fist with your other hand near the top of the stomach, just below the center of the rib cage. Make a quick, hard movement, inward and upward. In infants, place the infant's stomach down across your forearm and give 5 thumps on the infant's back with heel of your hand. When you are alone and choking occurs, place your fist above your navel while grasping fist with other hand. Leaning over a chair or countertop, drive your fist towards yourself with an upward thrust.
Choking often results when a casualty inhales food or an object whilst running, laughing or crying. Choking prevents breathing and can be partial or complete. Partial choking allows some, although inadequate, flow of air into the lungs. If the airway is partially obstructed and the casualty can breathe, speak, cry or cough, the first aider should lean the casualty forward and encourage them to cough to remove the object. If the obstruction persists and the airway is not clearing, seek medical attention and instructions urgently. Prolonged or complete airway obstruction is potentially fatal. If the casualty is unable to breathe, speak, cry or cough, the airway is fully blocked. They may be clutching at their throat, have increasing blueness of the face, neck, ears and fingernails, and may become unconscious. Position the casualty leaning forward and initially give 3 or 4 sharp, firm back blows between the shoulder blades. If back blows are unsuccessful, the first aider should perform up to 5 chest thrusts. These are given in the same position as CPR. Check after each thrust to see if the obstruction has been cleared. If the chest thrusts are not successful, alternate 5 back blows with 5 chest thrusts and seek medical attention and instructions urgently. The choking infant or child is managed slightly differently. A child with partial airway obstruction should be allowed to cough and may be placed in a steep head-down position over the first aider's knee. If the child's airway is totally obstructed, back blows are delivered. Again, if back blows are unsuccessful, the first aider should perform up to 5 chest thrusts.
Cardiac arrest is the condition in which circulation ceases and vital organs are deprived of oxygen. Cardiopulmonary resuscitation or CPR is a combination of chest compression and rescue breathing. This must be combined for effective resuscitation of the victim of cardiac arrest.
We'll practice using the memory word ABCABS in a cycle of care as you learn emergency first response skills. The meaning of the memory word ABCABS is as follows. Within the AB portion of the memory word, the first A in ABCABS stands for airway. Essentially, the A reminds you to ask the question, is the patient's airway open? Also within the AB portion of the memory word, the first B in ABCABS stands for breathing. This letter reminds you to ask a question, is the patient breathing normally? In the cycle of care, you begin by initiating a very quick check of the patient, attempting to answer these 2 questions. Is the patient's airway open and is he breathing normally? If the patient's airway is open but he's not breathing normally, then call emergency medical services and quickly move into the cycle of care. Within the memory word ABCABS, the CAB portion of the word reminds you how to perform CPR. Let's see how. CAB stands for chest compressions, airway open, and breathing for the patient. When a patient's not breathing normally, you must act immediately to provide chest compressions. After chest compressions, you open the patient's airway and then breathe for the patient. As defined earlier, this is how CPR is administered. After breathing for the patient, you continue to move through the cycle of care by returning back to chest compressions, opening the airway, and breathing for the patient. You continue with the cycle of care until professional help or an automated external defibrillator, AED, arrives.